Everyone, today we will continue with our tutorial on the signs of the brain. We have many more signs left. We'll try to cover them in the next sessions. So what do we have here? What's going on? It's a dural tail. Some people call it dove tail. Okay, dove الحمامة يعني الحمامة bird, kind of a bird. Okay, this is the dove tail sign. It's the same, almost the same as dural tail. Okay, so there is as you can see enhancing left cavernous sinus or cellular mass that encases and narrows the cavernous ICA. This is a very important thing to notice. The ICA here is encased and narrowed with extension, the dural extension along the left sphenoid wing. You can see here and here the dural tail. It has a differential diagnosis of number one is a meningioma, can be a lymphoma or a granulomatous disease. This can show this dove tail sign. The cavernous sinus meningiomas may extend posteriorly along the dura with a smooth bulging of the tentorium cerebelli, giving what's called the dove's tail appearance. This widening, fanning, okay? Lymphoma and granulomatous disease can also occasionally involve the tentorium, but tend to have more infiltrative growth pattern. Other primary metastatic tumors in this location usually have more tumefactive appearance with resultant mass effect, okay? Now, this is a difficult one. What do you think is going on here? Sorry? Omega sign. What else? It has different names. First of all, can be called ducky breast, epsilon sign, knob sign, knee sign, reverse omega, sigmoid hook sign. All signs for the same appearance. So, what pathology does that indicate? Oh, that's what I'm asking. What kind of, what does this indicate? That's a normal anatomical feature, okay? The ducky breast, epsilon knob, the reversed omega or sigmoid hook sign. You can see this hook or, I don't know, something bulging here, like the beak of this duck. This indicates the central sulcus enclosing the motor hand region, which is a normal appearance in the brain MRI. In this brain MRI, you should keep in mind that the central sulcus is an important landmark of the brain that separates the frontal from the parietal lobes as well as the primary motor and sensory motor cortex. The mid portion of the central sulcus is focally indented by the posterior precentral gyrus, which resembles the upside down Greek letter omega in the axial plane and sigma in the sagittal plane. When a double gyrus is present, the appearance mimics the letter epsilon. In normal brains, these findings are highly accurate and reproducible landmarks for the motor hand region. When they are looking for the motor hand, especially in neurosurgical pre-op evaluation, we should be careful. This area is usually indicates the motor hand region. Okay? Now, what do you see here? What's going on? Describe, what do you see? There is a lesion, it's intraaxial, it has ring enhancement, surrounding edema, exactly, and it's not one lesion, there are at least two, if not more, okay? So, the sign here is what's called cluster sign, daughter sign, or secondary sign, okay? So, as we said, there are two ring enhancing lesions and several adjacent enhancing nodules in the right precentral gyrus surrounding vasogenic edema. It's very it's very indicative of an abscess, cerebral abscess, okay? Causes of cerebral abscess can be penetrating trauma, surgery, direct spread of adjacent infection, or hematogenous dissemination. Various bacterial, fungal, parasitic pathogens have been described. 4 stages of evolution have been described at imaging. which is the spectrum of development of the abscess. there are 4 stages, okay? From soft tissue phlegmon to liquefied abscess. The stages are as the following. First, there will be early cerebritis from 1 to 3 days. Then late cerebritis from 4 to 7 days. So early, late cerebritis, early capsule and late capsule. Early capsule is from 10 to 14 and more than 14 days. If untreated, the infection progresses formation of one of multiple secondary or daughter abscesses adjacent to and continuous with the parent abscess. There is a tendency for evagination towards the deep or ventricular margin, what we call dimple sign. We saw it in the previous session, the dimple sign. The daughter appearance should be distinguished from satellite lesion seen with the brain tumors. These can be remote from the primary lesion, reflecting microscopic tumor infiltration or metastatic dissemination, the satellite lesion, while the daughter cysts are just adjacent cysts. It's the same abscess extending to the continuous tissues that are in front of it, okay? In addition, tumor growth is slow compared to the rapid evolution of the cerebral infection. Keep in mind timeline, abscess will develop from 0 to full to the late abscess in like 2 weeks. Tumor will need months, okay? In addition to the clinical data and the lab and all things. So, what's going here? What's the exam exactly? PET CT. Do you think this is PET? This is not a PET. This is SPECT. Okay. Which tracer do we have? Huh? What's the radio tracer? What's the substance? What's the material? Huh? لا. Huh? This is, we said it last session, this is iodine 123. Okay? Showing what's the pathology. What do you think is going on here? Last time we saw no uptake in the caudate head, and it was indicating what? Huntington, right? Yes. So now what's going on? This is what's called coma or crescent appearance, and it is a normal iodine 123 scan. Okay? Normal bilateral uptake in the caudate and the putamen. Last time we didn't see uptake in the caudate, if you remember. Whenever there is movement disorder and dementia in the elderly population, there will be a variety of etiologies. When there is diagnostic uncertainty whether it is a Parkinsonism or other disorders, you should order a baseline SPECT, a single photon emission computed tomography, which can be performed with dopamine transporter, iodine 123, commercially known as DAT scan, the radioisotope called DAT scan. Okay? An abnormal appearance is absence of putaminal uptake with normal or decreased caudate uptake, which may be unilateral or bilateral, what we call period sign, indicating nigrostriatal neurodegenerative condition like Parkinson's disease, atypical Parkinsonism, Lewy body dementia, all give the same appearance. Okay? Normally there is bilateral symmetrical uptake in the caudate and the putamen, what's called coma sign, this sign. Okay? Indicating a non-nigrostriatal etiology like Alzheimer's dementia, essential tremor, vascular or drug-related, will not respond to dopamine therapy. So it is very important to know if it is normal appearance on SPECT, then dopamine therapy will not be needed because it is not dopaminergic degenerative disorder, it will not respond. If there is decreased uptake in the basal ganglia and the caudate and the putamen, this indicates a Parkinsonism-like or Parkinson disease, which might respond to dopamine treatment. So it will change the whole treatment plan. It's not very simple thing. So what do you have here? Diffuse meningeal enhancement or dural enhancement or pachymeningeal enhancement. What's the differential diagnosis for that? First, intracranial hypertension. Second, no. What? granulomatous disease, like in general, inflammation, infection in general. Okay, yeah. Malignancy should be kept in mind. Okay, and idiopathic hypertrophic pachymeningitis. Okay, so you can see diffuse enhancement of the dura mater. The whole dura is enhancing. The dura mater, they include the periosteum of the inner table of the skull and its meningeal reflection, like the falx cerebri, tentorium cerebelli, cavernous sinuses. Normally, the dura enhances mildly and discontinuously. The normal enhancement is part enhanced, then part enhanced, then not. When it is diffuse enhancement, the whole dura is enhancing. There is something abnormal when it is can be seen in intracranial hypotension, as what they call Csf Hypovolemia, okay, for whatever reason, which can lead to secondary vasocongestion and interstitial edema in the dura mater. It can be idiopathic, like spontaneous intracranial hypotension, or secondary to lumbar puncture, trauma. Also, non-contrast FLAIR MRI sequence can also be effective for identifying pachymeningeal thickening and subdural effusions or hematomas in cases of CSF hypotension. The thin linear dural enhancement is a common finding in post-operative patients. Focal or diffuse dural enhancement has been described in various other inflammatory and autoimmune, infectious, and neoplastic conditions. When there is no primary cause identified, the condition they call is known as idiopathic hypertrophic pachymeningitis. When you look for a primary cause, nothing, no lumbar puncture, no trauma, no surgery, no nothing, you could just call it idiopathic hypertrophic pachymeningitis. Okay. Now, what's the sign here? Again, it is a dural tail sign, sometimes flare sign or meningeal signs. It indicates meningioma and other dural masses. As we said like a few minutes ago, there is a middle cranial fossa mass with a dural thickening and of the greater sphenoid wing, sorry, with posterior displacement of the right temporal gyri. You can see it here, and it indicates either meningioma or other dural masses. As we said, the presence of a dural tail sign or thickening and enhancement continuous with the intracranial mass is a classic for meningioma, but it is not diagnostic of meningioma, not always only meningioma. Other possibilities should be kept in mind. On contrast, enhanced T1 weighted MR scans, it's seen in about 60% of the cases. Occasionally, some other extra-axial peripherally located masses can show the same appearance, and sometimes intra-axial lesions can involve the dura. Intra-axial involving the dura, or dural masses, extra-axial. What are the intra-axial lesions that can involve the dura? They include metastasis, lymphoma, plasmacytoma, chloroma, glioma, nerve sheath tumor, pituitary lesions, inflammatory and granulomatous histiocytic diseases, infections, primary bone tumors, and vascular abnormalities. All of these, that extra-axial lesions can involve, intra-axial lesions can involve the dura. Now, the next one is an important sign. It's interesting. What is there? What's going on? What's this? Hot nose sign, or empty light bulb sign, hollow skull sign. It indicates brain death. Exactly. What is the exam? What is this? It's a nuclear study, of course. What is it? This is a technetium Hempel. Okay. It shows complete absence of the tracer uptake in the brain, with surrounding uptake in the scalp. The anterior planar image shows increased uptake in the nose and facial soft tissue, and indicates brain death. So accurate diagnosis of the brain death is critical before discontinuing life support in a comatose patient, particularly when organ donation is being considered. Okay? So the clinical examination is only reliable in the absence of hypothermia or barbiturate or sedatives, and hypnotics. If the diagnosis is unclear, a nuclear medicine brain scan can be performed using the technetium, different legends linked with technetium. These agents are lipophilic agents, selectively cross the blood-brain barrier taken up by the brain parenchyma. The initial dynamic flow image are acquired in the anterior projection, followed by delayed static blood pool images in the anterior, posterior, or lateral projections. Brain death is diagnosed when there is complete absence of tracer uptake within the cranium on all images. Care must be taken to distinguish the no flow from very slow flow within the cerebral arteries and or veins. Occlusions of the ICA prevents blood flow into the brain with increased collateral flow from the external carotid artery and resulting in increased uptake in the nasopharyngeal soft tissue and scalp, producing a hot nose and hollow skull sign. So what you're seeing is no flow in the internal carotid, increase the flow in the external carotid, the nose and the facial skeleton will get engorged and will take more more radioactive isotope than usual, giving us these signs. So in adults, a scalp band or tourniquet can be used to decrease scalp activity that might be confused with intracranial uptake. You know the skin will take the isotope. So they just put a rubber band or something on the scalp to decrease the uptake so that we can see the brain more obviously. Okay? If the patient's head is resting on a firm surface, a focal scalp compression may produce a photopenic defect known as the hollow sign. The patient's lying on a bed or table, the compression of the scalp posteriorly will give us what's called the hollow sign. Okay. What do you have here? There is some soft tissue with a calcification in the center of it, or okay, what's the sign? This is an engulfed calcification. Okay, the calcification is engulfed by something. Okay, and it includes this indicates pineal germ cell tumor. Okay, you can see there is around it hyperdense pineal mass with central calcification. So what is the differential diagnosis for pineal region solid masses? Pineal parenchymal tumors in general, like pineocytoma and pineal blastoma. طبعا of course germ cell tumor, metastasis, gliomas, lymphoma, neuroendocrine tumor, even meningioma, vascular lesions can happen here. The clinical symptoms includes Perinaud syndrome, which is what? Upward gaze palsy, exactly. Headache, ataxia. So to determine whether the lesion is pineal or parapineal in origin, you should review the images to identify the pineal gland and the surrounding structures. Okay, you look for the. Okay, you should also try to look for the internal cerebral veins superiorly, the midbrain tectum anteriorly, the cerebellar vermis inferiorly, tentorial incisora posteriorly. In the adults, physiologic calcification can help to identify the pineal gland. For true pineal masses, the pattern of calcification is helpful. Germ cell tumors tend to grow around and engulf the pre-existing pineal calcification, while the pineal parenchymal tumors, they explode. Germ cell tumors, they engulf the calcification, while pineoblastoma, pineocytoma, they explode, they expand the pineal calcification. Okay, we'll see something about it later. So what are the germ cell tumors that can happen here? They include germinoma, teratoma, embryonal carcinoma, endodermal sinus yolk sac tumor, choriocarcinoma. Germinomas are characteristically seen in young males, appear as hyperdense on CT with avid homogeneous enhancement, can be multifocal with additional lesion in the supracellular region, what we call bifocal germinoma, also in the basal ganglia, the thalami. These tumors are very sensitive to radiation and or chemotherapy, often resolving completely after treatment. When pineal malignancy is diagnosed, the entire neuroaxis should be imaged to assess leptomeningeal spread of the disease. They spread and they respond very good, very beautifully to chemo and radiotherapy. So they will be very dramatic response after initiation of treatment. So, what's going on here? How will you describe this appearance? Dilatation of the ventricle, focal dilatation or saccular, or just like what you said.
This is
Intraventricular arachnoidosis, some people say. No, this is what we call trapped ventricle. Okay, just like she said, it's not lesion, it's the focal hydrocephalus, focal dilated ventricular horn. Okay. Again, it has a differential diagnosis of intraventricular mass or adhesion or extraventricular mass, making like compression on this part of the ventricle. Okay, and you can see this can show a cystic mass in the left atrium with asymmetric dilatation of the left occipital horn, something that causes focal dilatation of the ventricle. Okay, it's isolated ventricular dilatation caused by blockage of CSF outflow, representing a focal form of obstructive hydrocephalus. The causes include prior surgery, trauma, infection, residual adhesions, intraventricular neoplasms or cysts, extraventricular lesions causing asymmetric mass effect. The lateral ventricle are most commonly affected, but rare entrapment of the third or fourth ventricle can also occur. But most commonly it's in the lateral ventricle. It's the most, the largest one and the most complicated anatomy. Okay. So, what do we have here? It's a very characteristic pattern. What do they call it? It's very early onset of what? Multiple sclerosis. What's the appearance? No. They call it dot dash, dot dash, dot dash. نقطة فاصلة نقطة فاصلة dot dash appearance. This is what we call by dot dash appearance. Okay, which indicates yeah, in the same there was the beads, the Dawson finger. The earliest one is this. It will progress to the beads of the yeah, and then the full-blown MS is the Dawson finger appearance. Okay. This is ependymal dot dash sign. There are subcallosal hyper-intense foci separated by normal ependyma. As we said, the MS is a chronic demyelinating disorder. There are spatial and temporal heterogeneity. On this thin section, FLAIR MR image irregularity of the ependymal stripe on the undersurface of the corpus callosum with two or more rounded hyper-intense dots are seen with intervening normal ependymal surfaces, which is the dashes. The lesions are not oriented perpendicular to the ependyma in contrast to subcallosal striations and the Dawson fingers. This finding has been shown to be highly sensitive and specific for detection of early MS, particularly in younger patients. Okay, so we should be careful for that.
So FLAIR is very sensitive.
FLAIR is very sensitive in young patients for the earliest, and keep in mind this is sagittal FLAIR, which we rarely do here as our protocol. We should change the protocol maybe, especially in patients for suspected MS. Okay. What do we have here? Well, we're not looking. No, this is not a DWI. There are multiple, like cavities, like holes. Okay. This has a differential diagnosis of what? First, the sign is the appearance, what's called honeycomb or Swiss cheese appearance. Swiss cheeses have multiple holes within it. The honeycomb also honeycombing, like we see in the lung, the same thing in the brain. The findings is the same. The differential diagnosis includes first, dilated Verka-Rubin spaces, exactly. Second, lacunar infarcts, like you said, and multiple sclerosis the burnt out lesion can show this appearance, and mucopolysaccharidosis, of course. Okay. So as we can see, there are numerous cystic spaces through the midbrain, through the brain, particularly in the high convexity of the white matter, the centrum semiovale, the corpus callosum. The differential diagnosis includes dilated Verka-Rubin spaces or perivascular spaces, which can be a normal finding, especially in elderly, mucopolysaccharidosis, burnt out lesions of multiple sclerosis, and lacunar infarcts. Okay?
The same case شفنا باليومي
Yeah, we see it all the time, and خصوصا in elderly.
يعني قالوا amyloidosis مو amyloidosis
Can be. We need a biopsy to diagnose amyloidosis. In the susceptibility weighted imaging, you will see microhemorrhages. You see the microhemorrhages. Okay. So, these are the Verka-Rubin spaces or the perivascular spaces. They contain interstitial fluid surrounding the vessels, and they occur from the subarachnoid space to the brain parenchyma. So the small Verka-Rubin spaces are normally seen at imaging, increasing in size and number with advancing age. The dilated Verka-Rubin spaces are seen in three typical locations. The type 1 is the basal ganglia. The type 2 is the high convexity of the brain, of the cerebral hemispheres, and type 3 is in the midbrain. Diffusely enlarged Verka-Rubin spaces, they call it état crible. I don't know what's something in French. I don't know what's that. Okay. This may be seen with the mucopolysaccharidosis, in which the enzyme deficiency result in the accumulation of metabolites in the perivascular spaces, dilating them. Okay, giving this cribriform appearance. Within the white matter, corpus callosum, and basal ganglia, toxic intracellular substrates can lead to cerebral atrophy, gliosis. MS can show diffuse punctate, usually less than 2 millimeter Verka-Rubin spaces. They describe it as sand-like appearance, very tiny holes. Okay, lacunar infarcts usually larger, more than 5 millimeter, and less symmetric in distribution. Okay. Now, what do you think is going on here? This is the opposite of the engulfed calcification. This is the exploded calcification. Okay. Yeah, the germinoma was the engulfed one of the pineal gland calcification. This is on the opposite. It's outside, outward bulging. Exploded calcification, and indicating pineal cell tumor or pineal parenchymal tumor like pineal blastoma or pineocytoma. Again, the differential diagnosis of the pineal region solid masses includes pineal parenchymal tumor, germ cell tumor, metastasis, glioma, lymphoma, neuroendocrine, meningioma, vascular lesions. I'm repeating it to keep it more in mind. Okay. The clinical symptoms include the Perinat syndrome, which is the upward gaze palsy, like we said, headache, and ataxia. So we should look for the calcification in the pineal calcification in the adults. Okay, the germinoma tumors tend to engulf the calcification, while the pineal parenchymal tend to explode or outward displace the pineal gland calcification. Okay. Pineal blastoma can be seen in patients with ocular retinoblastoma. They call it trilateral retinoblastoma, exactly, along with supracellular primitive neuroectodermal tumors. They call it quadrilateral. So you have unilateral retinoblastoma, bilateral retinoblastoma, trilateral retinoblastoma with the pineal gland, and with the supracellular peanut, it is quadrilateral retinoblastoma. When a pineal malignancy is diagnosed, the entire neuroaxis should be imaged to assess for leptomeningeal spread of the disease. Okay? Very characteristic sign. What is it? Eye of the tiger sign. Exactly. What does it indicate? It is Haller-Worden-Spatz syndrome. Okay? Or what's called pantothenate kinase associated neurodegeneration. some sort of neurodegenerative disorder with a very long and very difficult name. Okay, and other extra Parkinsonian. We'll see a lot of signs for the neurodegenerative disease. They have a lot of different signs in the next sessions. Okay. Yeah. Okay. It's the Haller-Warden-Spatz syndrome refers to a spectrum of pediatric neurodegenerative disorders where there's abnormal iron deposition in the basal ganglia. The symptoms begin in childhood with a progressive extrapyramidal dysfunction, cause rigidity, dystonia, impaired postural reflexes, and progressive dementia. This syndrome is most common subtype of neurodegenerative disorders in the childhood period. On the T2 weighted and susceptibility weighted MR images, the globus pallidus demonstrate high signal intensity within hypointense REM, which is the eye of the tiger sign. Other extrapyramidal Parkinsonian disorders such as corticospinal degeneration, early onset levodopa responsive Parkinsonism, and the progressive supranuclear palsy can have similar imaging findings, and the clinical correlation is crucial for the diagnosis. Always clinical. This case, you need to, it must be a child to diagnose that. Okay, you can't diagnose that in older age group. Okay, any questions?
Thank you.
Everything okay? Good. We will continue maybe on the next session. Thank you very much.